Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, welcome to this week's episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. As always, it's an honor to be spending this time with you. If you tuned into last week's episode, which was episode number 187, then you met psychologist Louise Sharp, who shared her current research and discussed the essential components of psychological therapy for effective pain management. Her research distilled over 50 components of psychological treatment for pain into three essentials, which were psychoeducation, cognitive approaches, and strategies to increase physical activity. In her paper, she named these three as the gold standard for pain care. I enjoyed this episode with Professor Sharp. I believe her research and interview is useful and can help inform clinical practice. Make sure to give it a listen before you dive into today's episode. Now, while I was doing some research, I came across a commentary in response to the paper Professor Sharp published. This commentary was written by Professor Lance McCracken and published in the European Journal of Pain. For those of you who may not know Lance McCracken, he is a professor of clinical psychology and head of the Division of Clinical Psychology at Uppsala University in Sweden. He has worked as a clinician and conducted research into chronic pain treatment for more than 30 years, and he actively contributes to the evidence base on acceptance and commitment therapy for chronic pain. The title of his commentary was Necessary Components of Psychological Treatment for Chronic Pain, More Packages for Groups, or Process-Based Therapy for Individuals. In his commentary, Professor McCracken proposes, instead of studying the components of psychological treatment, if we want better treatments for pain, what we mainly need to identify is the processes of change known to have an impact on outcomes. I was interested in Lance's commentary and his perspective, so I invited him to come speak to us, and this leads us to today's episode, where Professor McCracken discusses process-based therapy. Process-based approaches have been growing, and some say that process-based therapy should be the new gold standard of care because they can target a broader range of problems than diagnosis-based protocols, can target multiple problems at once, and are more easily individualized and administered to the client. So in today's episode, you'll learn all about process-based therapy, the science and evidence behind process-based therapy, how it can help clinicians more effectively treat pain, and how it differs from protocols that focus on specific syndromes. Okay, without further ado, let's meet Professor Lance McCracken and learn all about process-based therapy. Hey, Lance, thanks for joining me this week for the podcast.
Hi, Joe. How are you?
Great. It's great to have you here. I've been looking forward to our chat. I came across a commentary that you wrote in the European Journal of Pain, which talks about maybe potentially moving from components of psychological treatment, talking more about process. So I'm excited to talk to you about it. And I think probably a good place to start is you've dedicated over 30 years now to researching the psychology of pain. So give us your view of what the current status of chronic pain treatment is in your view.
Yes, sure. I mean, thank you for reading the commentary and for inviting me to be here to speak with you. I appreciate it. Where things are at, I always say these days that it's a good time. It's a good time to be interested in psychology and chronic pain and treatment development because we've already achieved a lot. CBT and various versions of CBT we know work well. They produce benefits for people with chronic pain. And so we're sort of over that hurdle. I mean, we have evidence, we know that there's benefit. And so now we have these other interesting questions like who benefits and what do they benefit from and how do they benefit and how can we make it last and how can we make the benefits even greater? So we have a job to do or many jobs to do, but we all already have a success story. So I think that's where we're at. We also have a lot of, I would say, innovative and interesting new options. um, things like new psychological processes that we didn't used to appreciate to the same degree. We have more modes of delivery that we know can be effective. So we have new technology. We can use people's smartphones. We could monitor people in more ways than we used to be able to do. And so, I mean, there's a lot of science and evidence behind us and a lot of opportunity. And we have some serious questions that we still need to answer. And those are these things that are always called the who, how, what, where, when, or whatever you want to call it, for whom, in what circumstances, what methods, by what mechanism. Those questions are, I think, what we're wrestling with.
Right. So kind of like the 10,000 foot view, you're saying that cognitive behavioral therapy has come a long way and there's good evidence to support it for the treatment of chronic pain.
Indeed.
And you're talking more along the lines of process-based therapy, which is kind of what the title of this episode is about. Somewhere potentially in the middle of those two are the components. And that's what your colleague Louise Sharp wrote a paper on, the necessary components of psychological treatments in chronic pain management, a Delphi study. And that's what your commentary was in relation to. And she boiled down those components into three categories. And if I remember correctly, it's psychoeducation, CBT, and some type of activity engagement. And her study is interesting because it took a whole lot of different types of components and boiled it down to three.
Yeah.
What are the potential, from your view, the pros and cons of that?
I mean, I agree with the spirit of what Louise and her colleagues are meaning to do. I mean, we're all trying to do the same thing in a sense. We all want to refine treatments and make them more impactful. And so one way to do it is to think about all of the components that get delivered or have been delivered historically, and then find the ones that, that exert the most impact, and find it by asking the people who research the treatments and the people who deliver the treatments to produce a consensus. Mm-hmm. So this is a way to do it. This is, you know, the intention is right on, if you ask me. But there's also certain limitations here. One limitation for me is that this kind of approach brings us back to things that we've already done, to review them and then select from them to pick the ones that we think will work the best. And so it's a little bit, I don't mean this in a pejorative way, but it's a little bit backward looking. That does sound pejorative, but I hope she isn't listening. To me, it doesn't begin with a kind of a formulation of treatment as a whole. It kind of really is a must find the right parts kind of approach. Mm-hmm. So I don't think it really radically reorganizes what we could do, nor does it give a great organization to how to do that better. And so, you know, it is what it is. I think it could produce better treatments, but I think there are other ways to innovate. There are other ways to, you know, produce the next treatment prototypes and things such as that. And I guess that's what we'll talk about. So there's pluses and minuses. I don't want to put down what they've done, because I think the intention is right on, and I do think for many people who read it, they'll take learning from it, and they'll be able to apply it, and practical benefits could come from that. But I think the view I have is that we could do this in a more radical way. We could really more deeply get underneath how we have been delivering treatment, and then more radically reorganize it outside of the confines of kind of where we've been in the past.
Yeah. Does it potentially run the risk of someone reading the paper and just taking those three components, let's say psychoeducation, CBT, and some type of activity engagement, and say, okay, that's what our entire program is going to be like, whether it's an inpatient program or whether it's an app on a phone, where it just boils it down to that and it takes away the individuality of care?
Yes, I mean, I think what I wrote in my commentary, if I can remember it, is that I think there is a risk that people will take those three things, then focus too much on them, and then maybe rely on, those components as their guide too much, and will take too much comfort or too much confidence in the delivery of those, thinking if I can hit those, I'm doing a good job. But you can't really, as you yourself mentioned right there, in a way that all by itself leaves out tracking the individual, noticing the difference between what different individuals might need. The fact that this summary comes from group data from group delivery experience boiled down by consensus. So I think there's a lot of heterogeneity, there's a lot of individual patient circumstances, and a lot of individual patient need hidden inside that summary, of the summarizing effects of consensus, group delivery, and group data. And so you take the lesson from what they've got there, and then if you could add these other pieces, detecting individual need, making sure you keep tracking the data of the individual. Don't choose a component from group data with the belief that it'll necessarily apply to a person. Mm-hmm. And then I would add a few more ingredients, and I'm sure in a moment we'll talk more about those. But I think the point is probably becoming obvious already to your listeners that this focus on components is a way to organize what one does next, and another way to do that would be, process-based therapy. So how does that contrast? I think that's sort of where we're getting to in a sense. Yeah.
The term process-based therapy is new to some people. I've actually even asked a couple of colleagues of mine who work in mental health, and they weren't really able to articulate it to me. And I actually had to do a lot of reading on my own to really get a good grasp of it, even though I've read some of it myself. But tell us how process-based therapy is an evolution from, let's say, the components.
Yes. I mean, for one thing, it's evolutionary because it is different. Okay, so if you think about how evolution works, is you have to have variability. Without any variability, you can't get selection. Without selection and retention, you don't have different forms down the line. You can't, you can't create increasingly more effective forms because you don't have any variability. So one thing we can say about process-based therapy, whatever it is, if it is different from what we're doing, that alone could be a good thing because it's variability. We let that run in the environment, and we see what works better, and what works better gets selected for use, and things could be good. But there's no apology needed in this issue here of finding difficulty in uncovering what is process-based therapy, because although the term has not, the term has been known, but I wouldn't say it's been widely known, and it's probably only these days entering people's vocabulary. You'd have to track down a few particular people by name probably to read about it in any volume, and it's those who are speaking about it the most these days probably would be Stefan Hoffman and Stephen Hayes and others, but it's there's a relatively small number of people who are kind of promoting the virtues.
Mm-hmm. And it's, as you mentioned, Stephen Hayes, so ACT itself is a process-based therapy at heart.
Yes, so it would be called by many people the kind of sort of an early prototype of a process-based therapy. but it has to be said that, you know, ACT began to be used. It began to be first be tested a bit in the 80s, and then there was a book, a full-length book in 1999. But at that time, I think you'd be hard pressed to have found the term process-based therapy in the book in 1999. Although it's, you know, it is inherently process-based. I'm not sure that the term was popularly used, but it certainly is. I mean, it's of known therapies, it is one that certainly sort of fits the mantle, fits the picture of what is a process-based therapy.
And then for other practitioners who are listening, if we kind of, you know, pull out a little bit and widen the lens, there are processes obviously that are at work in other types of therapy or therapies. What other types? So ACT has 6 processes that people are familiar with if they're familiar with ACT. What other types of processes might a practitioner relate to or start to become aware of from that?
Yeah. So the first thing to say is, if there's any treatment that's happening that is generating any impact, intrinsically, inherently, essentially inside there is a process. Now that process may not be, it may be that it is not being consciously, intentionally, incrementally manipulated to produce the outcome desired. But there will be a process. If there's change, there's a process. If there's an incremental change in directly at the end of the methods applied, that in turn is related to an incremental change in the outcomes of interest, then it's process. But it's not process-based unless it is the intention, the purposeful choice of the person delivering the treatment to make those processes the heart, the focus, the sort of organizing component of the treatment.
Right.
So it's that intentionality, I guess you could say.
So for example, from a physiotherapist perspective, the primary cognitive behavioral intervention they're using is probably pain education. So the reconceptualization of pain, that would be a process that they would intentionally be applying to care.
Yes.
And, you know, and likewise, let's say more from a traditional cognitive behavioral intervention, cognitive restructuring, I guess the restructuring itself is the procedure or the component, but the reappraisal would be the process.
Yeah, I mean, so at this stage in history, you know, we've not had a history of being careful with our statements of what is a process and what is not. And you very nicely hit on one issue, and that is, for a lot of the terms, they're used interchangeably as method and process, like mindfulness. Is mindfulness method or process? Exposure, is exposure something you do, or is it something that happens when you do what you do? Is it the process or the method? And education, what is that? Is education the process, or is the process knowledge enhancement, or what? So anyhow, I mean, we have some ways to go, I think, to refine our terms, to really nail down our processes so that the ways we name them have precision. You know, they're only what they say they are and can't be confused with something else. We'll need to move ahead with developing criteria for what makes something a process compared to something that isn't a process. But I mean, so we are where we are in a slightly sloppy stage of, you know, process and mechanism. And, you know, it's, you know, we're making progress. I think we know that some of these challenges are there. But yes, I mean, it is, as you say, physiotherapists have their processes in what they do. Some of them when they're seeking psychological behavioral change, and then your other ones, which would be more within your domain, that are non-psychological processes.
So as a pain practitioner, it starts to make me think, do we have an adequate set of processes identified for chronic pain yet, or which ones do we potentially know a little bit about?
Yeah. So, I mean, again, what we've done a couple times in this discussion is if you just walk backward a little bit for a minute and you think about what are we talking about here. So for any individual that we see, we're going to have outcomes of interest. And in pain management, we have some conventional ones like pain interference or disability or depression or pain intensity. And that one we'll have a range of variables that we know are correlated with those. And where the presumption is if you manipulate that correlated variable, it'll impact on your outcome of interest. And so if you then add to that, so we've said another thing, which is these links are very individual. They're based on a person's learning history and their situation. And then if you add a couple other features to their individual and you say they may be bidirectional, the relationships between these process type variables and outcomes go in both directions. They're dynamic. They change during the course of treatment. They may go back and forth, the strength, or they may strengthen in their impact or lessen in their impact. So saying these few things, they're multivariate. They're multivariate, bidirectional, dynamic, and individual. Mm. And they are the kind of things that we've just said. And they are things like something about catastrophizing, for example. Something about avoidance, probably. Or by the same token, something about behavioral engagement or behavioral activation. I'd say there's going to be an attentional sort of process domain we probably need to nail down. Something about awareness and attention. We don't have that many more. I mean, so ACT is based on a psychological flexibility, 6-facet or 3-dimension open, aware, and engaged model. I think people interested in psychological flexibility and ACT will see evidence, for these facets, but not everyone would agree with that. And so you have to begin to ask questions about what's enough evidence to call something an evidence-based process. But that's a little bit all over the place, but you see what I mean. I mean, there's probably some that look pretty strong. Most people would agree. But I think we're still populating this space of evidence-based processes.
So we're trying to figure out the procedures that have an impact on the process that impacts behavior change ultimately.
Yeah.
And that has to probably be individualized for the person that you're treating.
Everything that you've said is right on. Exactly. So we haven't talked a lot about method, but if you got processes in there, one thing that you want them to be is empirically related to your outcomes of interest. They have a empirically demonstrated relationship with your outcomes. And in the other direction, they have a empirically demonstrated relationship with the methods that you would, let's say, intend to use to operate on your processes. So you get those links in 2 directions, and that's really what supports the function and influence. It makes the processes relevant.
Yeah, it's interesting because that fits really well with personalized and precision medicine. Although then it makes me think, does process-based therapy not fit as well with group therapy?
We need another podcast on that topic. I would say, without trying to start any trouble, that it's hard for groups to individualize group treatment to be individualized around every single individual in the group. Mm-hmm. There's one point of delivery in the room, a therapist. You'll get other points of delivery, by the way, the other patients or the other participants. So for any person, everyone else in the room is a potential point of delivery. And but not all of the therapist behavior or the other people's behavior, whether it's therapeutic or counter-therapeutic, can even possibly be calibrated individualistically to any one person in the room. So I wouldn't stack up group treatment delivery as the prototype process-based, because process-based really means doing what for this individual in these circumstances, what is going to impact on their priority outcome issues. And even the outcomes, they kind of have to be idiographic, meaning they have to be pertinent and based in this individual's priorities. And
Yeah.
hard to swing that in group treatment and aggregated group data.
It's interesting. It starts to kind of blow your mind after a while if you start to think about all the different levels it can have an impact on. Like, for example, protocols, which are very popular, I think, especially for newer therapists, because it gives them a little bit of confidence and, almost a roadmap and a how-to guide. Can you protocolize process-based therapy then?
I think you can lay down a design, but I don't think but you can't pre-orchestrate moment by moment, because that would sort of defy the purpose. So if you have to have a kind of a dynamic customizability. So if all your sessions are preordained and all of the minutes during your session are already spoken for, you don't have any customizability anymore. So but you could say that what we need, that you could have a protocol that said what you need as your instruments are these instruments. Okay. List of empirically supported processes of change. Your methods that you're competent in utilizing. Your tracking methods for processes that may be relevant, and probably your outcomes to know when you got there. And then a process of, feeding the process information to the delivery, to the therapist, to select the next method based on the process being targeted. So in a way, that's a pretty unusual protocol. But if you say a protocol is a list of your tools, yes. And an instruction set which says what we've been talking about so far: individual, customizable, dynamic, watch out for bidirectional relations, multivariate, be situational and individual, be contextual. Yeah. So a nice set of flexible reminders, but not a session by session protocol.
Right.
Yeah.
So if there's a clinician listening to this and they want to start to practice in this way, so to speak, more from a process-based approach, are there process measures they can start to use in clinical practice to measure certain processes that may have an influence on the patients they're treating?
Yes and no. I'd say one of our challenges in our field, if we want to equip ourselves to do process-based therapy, is the development of very brief methods that are useful for repeated application, repeated use, repeated administration, that could be used daily or more than once daily. You need that fine-grained, detailed, sort of dense, intensive assessment over time. Skilled clinicians with training in the development of measures can sort of design their own, can pilot them and use them. Clinicians already do this. I must say, we are not overflowing with all kinds of validated instruments that anyone can select for use. You can read and you could find what people have used, get copies of what they use. You will find, I believe, that many people are using instruments like daily diaries or what have you, that they were developed for the study that they're doing,
right?
And weren't validated in a study of their own in a unique and new way, specifically suited to intensive longitudinal data. But there are examples out there. I know I read them lately that there are single case experimental studies, N of 1, replicated N of 1 series, and they get their data in a repeated fashion, they graph it. So they are using measures, but we haven't, as I say, we haven't really reached the point where we have a whole treasure trove of validated measures to pick from. It's kind of more like recently made for a purpose. Now you're borrowing them for something else.
If we had that, then it may influence a practitioner's not only evaluation, but then their goal setting and what happens in the care of that patient.
Yeah, indeed. Yeah. I mean, because if you're not tracking process, it's hard to calibrate and choose process, you know, and it's hard to know if what you did hit the target you intended it to target. So, I mean, you are saying, yeah, in some ways a slightly discouraging thing because of what I said before, but it's right on. I mean, if we can't track, measure, reflect these things, it's going to be really hard for that information to guide choice. Yeah.
So people are still, so they're still tracking, let's say, interventions and components and in essence, symptoms and potentially functional outcomes, I guess.
Yeah, well, implicitly, I think they're tracking, implicitly people they have the protocol, they have the list of methods. The method is they know the methods for this session. Implicitly, they're tracking because they're implicitly checking off, yes, I did psychoeducation today. Yeah. I did education on depression, or I did goal setting. I did SMART goals. So yeah, I mean, that's right. That's exactly right. So historically, we have tracked method, really. Protocol says do these methods, and then we implicitly check them off when we have done. Of course, that doesn't mean that we have measured the impact of the method. We've measured the delivery of the method. We don't know if functionally the method hit home or not. Yeah.
How do you see yourself integrating process-based therapy into your future research with your group?
Well, I mean, we are right now putting our heads together and trying to drill down into exactly the things that we're talking about. We are scouring the literature to understand. We're kind of implicitly doing a kind of a scoping review. We're interested in idiographic methods, N of one, single case experimental design methods, those, you know, the very individual approach, and what measures people use when they test and examine these approaches. We'd like to understand the lay of the land, you know, all of the territory, the scope of what is used, how those measures are developed and validated, what domains are represented, and sort of what's sort of implicitly what's current best practice. So that's a step. We know that we have used some, you know, platforms to get daily data on people's phones. We're still working on, you know, finding maybe the best platform to do that. And we want to examine mediation and mechanism in replicated single case data. We know there are some methods for doing that. That's something else we're looking into. So just, you know, if you remember where we've been, RCTs with mediation and moderation analyses, pre-post follow-up data, not a lot of intensive daily data, but that's the classic. This is what we've done. So we're trying to move away from that. Smaller numbers, more intensive data, so not as many people, more data over time, and then adopting our measures, our analytic approach, our approach to mediation and moderation accordingly. But we're really, I mean, we are just at the beginning phases. We're just piloting things and reading our butts off.
Yeah, I'm noticing you're almost kind of going in the reverse of evidence-based research in a way, which makes sense because there may be potentially, you're obviously much more versed in research than I am, but there may be more potential for a single subject design or a case study with regard to process-based therapy since it is so individualized.
Yeah. Yeah. I mean, I'll tell you just a short story about one thing that we tried very hard to do, because most of my experience is not in RCTs. We've done some RCTs, but what we've done is a lot of studies in actual clinical practice, a lot of effectiveness studies, like what happens in actual treatment. And we've tried rather hard to be process-based in our approach to that, and tried to find potential mechanisms and potential moderators, variables from baseline that can be used to determine how to customize. And we've just had such a miserable time, specifically with that last one. How do you identify variables at baseline that are related to whether people are going to do well in one thing or another thing? So the kind of customizing or individualizing information. And we've just really completely not been able to find anything. And it finally dawned on us, our current hypothesis, which is when you have heterogeneity within groups, heterogeneity between groups added together into larger groups of aggregated data, you have treatment, you have treatment teams that vary in competency and fidelity. You have cross-center changes. You have differences in people's pain conditions, their personal history, and relevant psychological processes. You are just buried in heterogeneity. And how could you expect to find predictors or moderators or even clean mechanisms in all of this extreme heterogeneity? It just dawned on us that that can't be possible. It can't be that processes change in an even, neat, tidy, linear fashion over exactly a 3-week period of time in everyone to the same extent. Can't be. And so if that's your model of mechanism, which can't work, your model of moderators can't work either. Because if you can't figure out mechanism or mediation, you just don't have a hope of really nailing predictors of outcome. So that's, I think, what kind of has really brought us around to this. And yes, it does sound like going like sort of historically in the wrong direction, because we've hit the pinnacle of treatment, outcome assessment research, large RCTs with moderation, mediation, and health economic analyses. And yeah, I mean, I think that stuff never needs to be canceled. I don't think it's bad. We shouldn't stop it. But I think our argument would be, we better start complementing that, adding to that or extending that with a very different way to look at the data, to make sure that if there is something obscured in all of that aggregated data, that we learn about it, we learn what it is.
It's interesting when you're talking about that, because I attended an ACT boot camp a couple of years ago, and I sat next to, I believe she was a social worker who worked at one of the VAs in the United States. And she had mentioned to me that to work at the VA, I believe she was working in a trauma setting, that they had to be competent in 18 different psychotherapies. And I was like, wow, I'm not trained in psychotherapy, but I'm like, that sounds like a lot to me for any human being to maintain over the course of a long period of time. So I'm wondering if maybe in some ways process-based therapy could be simpler for practitioners to apply in practice versus the multitude of different theories that almost all our professions have now.
Totally. Now, we should go talk to that person, because it can't be 18 different psychotherapy models of therapy. It could be 18 different methods. anyhow, that's a different story. But yes, I mean, so one thing that is a complaint, I think, for many practicing clinicians is that that we seem to have been told in the past that the way to do evidence-based therapy was to find the protocol that was tested in an RCT or multiple RCTs and verified as the protocol that produces the good effect. And if you do that protocol, you're doing evidence-based practice. And we seem to have been told that that's the way to do it. The trouble is, these are all disorder specific. So if you want to get into this game of protocols, there's a lot of protocols.
Yeah.
Panic disorder, depression, social anxiety, generalized anxiety disorder, headache, low back pain, fibromyalgia.
Yeah.
The list goes on. And that's too much. That's too much to memorize. It becomes too many. And the secret, I think, hidden behind all those numerous protocols is that many of them actually are based on the same therapeutic processes inside. And so let's skip a step. Let's learn the processes and then produce the clinical technology needed to know when they are needed and do it that way instead of memorizing protocols or keeping a huge drawer full of protocols or a shelf or a library. Yeah.
I like that. It sounds like it simplifies things for a practitioner and maybe in a way gives them a little bit more confidence, especially maybe in the beginning of their career where they're, like you said, they're looking at, well, what protocol do I use for depression and fibromyalgia and, OCD, which is more common in psychology than in probably other fields. But even in physical therapy now, there's multiple protocols for different types of conditions. And they just the list just keeps growing and growing and growing over the course of the last 10 years. And most practitioners don't follow those protocols, to the T. So there, like as you mentioned, there should be something at work in all of them that has a commonality. And hopefully process-based therapy is that. We'll, of course, be watching your work, following you on PubMed, but let people know how they can follow you and learn more about your work as you venture into this.
Yeah. Well, I encourage people to either look me up at Uppsala University in the psychology department. You could see some of the stuff that's coming out of our group. Our research group is growing. I only arrived in Uppsala in 2018, and we've just taken on 3 new PhD students. So we have, I guess, high hopes for the future. But I'm where you find most people: ResearchGate and Google citations and Twitter. I'm just sort of popping my name somewhere, and follow me on Twitter. It might encourage me to tweet more, which probably wouldn't be a bad thing. I have a goal to be a more frequent tweeter and to write clearer, more clever, quality tweets. So I could use the help.
Right.
The traditional places. Yeah.
We'll definitely tag you on Twitter with this episode, of course, and everyone can follow you and learn more about Lance. He's a professor of clinical psychology and the head of the Division of Clinical Psychology at Uppsala University in Sweden. We'll link to his ResearchGate as well as his link there at the university. Of course, at the end of every episode, I ask you to share this with your friends and family and colleagues on Facebook, Twitter, LinkedIn, wherever you have people who are hanging out talking about the psychology of chronic pain and, of course, process-based therapy. I want to thank Lance for joining us this week, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.